Hello, this is julima Wellness Consultancy in Mulela in Theta in Juja in Kiambu in Kenya in East Africa, which is Africa. Let's move on together. Today we are talking about types of treatment setting. And what is a treatment setting? Treatment setting is the place or environment where substance abuse treatment services are provided. These environments may look very different to the outside observer and range from mostly restrictive to least restrictive. Restrictive refers to the degree of physical and social structure provided by the professional staff for the recovering substance abuser. For example, a highly restrictive environment would be considered a locked inpatient hospital setting where clients are encouraged to live and receive their treatment. In contrast, a weekly voluntary outpatient substance abuse treatment program would be considered a setting of less restrictions where clients generally reside in their homes and attend scheduled meetings with professionals at designated agencies, offices, sources, or treatment facilities. As mentioned in the previous chapter, clients fall within a range of diagnosis and severity of illness. In general, the more severe and substance abuse diagnosis, the more restricted the environment or setting that is recommended. This rationale suggests that clients need settings that match their diagnosis and degree of severity for treatment to be effective. Okay, then we got the types of treatment setting. First, we will start with medical detoxification and stabilizations. Detoxification is the safe and complete withdrawal in incapacitating substances such as alcohol, barbiturates, hallucinogens, and heroin. Detoxification units can be within hospital or free-standing units. Medical necessity is established before admissions and refer to the risk of medical problems, e.g. seizures or psychiatric difficulties, e.g. suicidal ideations. The client exhibits. This medical unit usually employ pharmacological detoxification protocols that are based on the type of drugs abused and the patient's concomitant medical conditions. These protocols include gradual taperings and the drugs over a period of several days or weeks. For example, heroin can be weaned from individuals and substituted with a longer-acting opioid such as methadone. Other medications may be administered to lessen physical and psychological symptoms associated with withdrawal. The length of stay usually less than 2 weeks. Detoxification should be considered only the beginnings of treatment. Many patients mistakenly believe that after detoxification, no further intervention is necessary. Transition plans should begin soon after admissions. The next treatment placement should be based on the patient's needs. However, follow-up treatment often depends on other factors such as community resources, ability to pay, and insurance coverage. detoxification setting, provide screening for presence of withdrawal symptoms or psychiatric conditions, on-site medical and psychiatric care that promotes safe and complete withdrawal, staff who structure and nurture the environment, staff who protect clients from self-harm or harm to others, and staff who educate and counsel clients about substance abuse and dependency. Okay, two, dual diagnosis hospital inpatients. Dual diagnosis programs are usually based in psychiatric hospital and are designed to treat clients with the presence of both serious psychiatric illness and substance abuse dependency. Services are provided to diagnose and treat substance dependency, as well as symptoms attributable to psychiatric illness. This condition must be assessed independently and in relation to the other presenting conditions or symptoms. This is done to withdraw the affected client safely from substances, stabilize the clients emotionally and physically, and identify and treat the concomitant disorders. The personnel's expertise is helping duly diagnosed clients stop abusing substances and maintain their psychiatric treatment regimens. This may include prescribed psychotropic medication, e.g., antidepressants, antipsychotic, and anxiety drugs. Specialized training in dual diagnosis require staff and counselors to understand how concomitant disorders can interact and manifest in the client's lives. Individuals may reside in their hospital units from several days to several weeks. Programs are designated for either adult or youth treatment. Dual diagnosis hospital inpatient setting provide on-site medical and psychiatric care and include 24 hours nursing and meal supervisions and locked units with limited access to family and friends. Personnel with specialized knowledge in dual diagnosis. 7, 14, or 28 days stay in protective, restricted environment. That time you can't see your child or your person. Psychiatrics and substance abuse crisis stabilizations, more intensive assessment and diagnostic services, and data intensive group contact with the other clients and staff. Staffs who will be met there are attending physicians or providers. In a medical hospital setting, the physician, psychologist, or other approved mental health professionals who attends the patient's stay is responsible for approving the course and the methods of treatments, and we assume dispensing or monitoring of correct medication, credentials by the hospital medical staff. Medical director, typically an addictions trained physician who oversees the delivery of services in the unit, not necessarily a direct provider of patient's care, assumes general supervision of the nursing staff, occasionally directly involved with addictions counselors, directly assigned to patient's care. Nursing staff, generally responsible for day-to-day patient's care, often 24 hours per day on site or directly supervising non-medical unit staff members, will help determine program procedures, patient's care, treatment, and discharge planning. Social workers will provide required transition, discharge, or placement planning. We assure all record documentation meets standards, often has a portion of his or her time allocated from the social services department to the chemical dependency unit, not required to be addiction satisfied. We conduct assessment and make treatment recommendations, often not the primary counselor or assigned therapist. In mental health workers, mental health professionals trained in the delivery of general mental health and counseling services, not typically the primary provider or attending practitioner, assist in treatment planning, conducting education portions of the IP meal, facilitating activity, therapy, or skill building groups on drug diagnosis units need not to be satisfied in addiction treatment. Satisfied substance abuse or addiction specialists or primary care counselors. In a medical facility, a member of the treatment team under the direction of the attending practitioner satisfied by the state as a trained counselor in the field of addictive disorders in residential, medical setting, often the primary counselor, therapist directly responsible for clinical care treatment, planning, education session, group treatment, and aftercare planning. In residential freestanding units may be a recovering individual with no primary or advanced degrees, but with technical approved training in the field of substance abuse treatment. Clinical director, generally a trained, advanced degrees mental health professional who is a certified or licensed addiction specialist, oversees the delivery of clinical care to patients and significant others, may directly provide the group and specialty services such as CD education, couples group therapy, multifamily therapy, and so on. Supervises primary counseling staff. If advanced in training, may supervise all medical and clinical functioning. Now we are in rehabilitations, free studying rehabilitation and residential programs. Rehabilitation programs. Rehabilitation programs are usually free-standing and hospital-based facilities that are often oriented to the well-recognized Minnesota model of addictions treatments, whose inpatients and outpatient treatment facility dedicated to treating alcoholics is considered to be one of the major contributors to the Minnesota model, founded in 1949. He then pioneered the 28 days rehabilitation program for alcoholics. Suggests that the early year of his den, McKellar suggests that the early year of his den contributed to the Minnesota model. A. The grace of a beautiful environment that promoted respect, understanding, and acceptance of the dignity of his client. B. A treatment-based essentialist on the program and process of AA. C. The belief that time away and association with other alcoholics was central to recovery. And D. A very simple program whose expectations were for all clients to make their beds, comfort themselves politely, attend the daily lectures on the 12 steps, and talk with one another while sitting around. Sitting 1949, over 100,000 men and women have gone through treatment on one of Hasidon's facilities. Today, the Minnesota model denotes an effective and frequently used philosophy and methodology of delivering treatment. It has elements of medical, disease, socio, psychological, and self-approaches. The medical element emphasizes a professional staff who direct and control the planning process, ethics, implementation, e.g., enforce and maintain facility rules, provide treatment recommendations and evaluations, educate clients about substance abuse. The social self-help elements encourage clients to be responsible for developing their own recovery within a context of help from peers and recovering staff. The medical elements of treatment suggest that chemical dependency is a disease, and all clients have the same disease. The disease is primarily pervasive and progressive. Loss of control and denial are primary characteristic. Recovering and non-recovering clinical staff are valued. Education and therapy are central to program effectiveness. Families should be included in treatment, and self-help group enhance treatment. The social and self-help elements of treatment suggest that planning for recovery is a skill acquired by clients. Experiential education is emphasized and encouraged. Self-governing peer support is stressed and encouraged. And developing sober, clean support network in the community prepare clients for leaving the rehabilitation programs. Detoxification. The detoxification phase is the process of safety and thoroughly relieving symptoms of intoxication in either a hospital or non-hospital community-based setting. Patients may already be detoxified at entry through many programs have their own detoxification facilities. Withdrawals from alcohol or drugs can be accomplished within several days to 1 week, depending on the substances abused and the client's unique physiologies. Once a client is detoxified and given medical clearance, he or she is then enrolled into the rehabilitation phase of treatment. Rehabilitations. The rehabilitation phase can occur in either inpatient or outpatient setting. Clients vary in drugs of choice and in mental health conditions. Daily routine for structured inpatient setting, e.g., group therapy, 12 steps supporting groups, recreation, community meetings are the same for all clients. Peer interactions and confrontations are encouraged to develop a recovering, supportive community atmosphere. The social milieu is an essential element of treatment and attended to by professional staff just as vigorously as any other services provided. Individuals' treatment plan, which will be described in detail later in this chapter, are used to guide treatment. These plans identify behavioral problems and develop goals and strategies for their resolutions. Common problems areas are maintaining abstinence, family relations, career decisions, and social interactions. Often a level system for privileges and benefits is used to encourage clients to participate successfully in the program. Inpatient stays are typically 21 or 28 days. Outpatient rehabilitations are less restrictive environment, typically includes group therapy meeting 3 times per week. Homework is given to extend learning into home and work environments. Clients maintain their place of residence and employment while committing to a program of recovery that include abstinence. If a client is unable to maintain sobriety and or is not making sufficient progress, a more restrictive environment, such as inpatient rehabilitation, might be recommended. Aftercare. Aftercare is the least restrictive phase of the Minnesota model and is considered to be a contribution of the rehabilitation process based on the notion that recovery from alcohol and drug is a lifelong endeavor. Aftercare helps clients transition into a sober, clean lifestyle that is lasting and integrated into their everyday lives. It is provided by the program for approximately 1 year and may take the form of weekly or bi-weekly individuals, family or group therapy. Consistent attendance of 12-step meeting is encouraged to help clients maintain their sobriety by deepening their connection with other recovering individuals. For most rehabilitation programs, psychiatric evaluations are usually done off-site, but some may have their own psychiatrist. Okay, from there is residential programs, but that we will hear later. My time have ended. Thank you, thank you. Keep on subscribing, keep on liking and commenting so that we will hold hands to help our society to come out from this substance abuse. And I know by the end of the day we will make it if we hold hands and team up to do so. Thank you, thank you.